Thank you for joining the webinar this evening. My name is Catherine Conway and I'm going to present the new Colonoscopy Clinical Care Standard. Joining me this evening is Professor Anne Duggan, Co-Chair of the Task Working Group, Siobhan McFadden and Anne Marr from the Commission of Safety and Quality in Healthcare. Just a little bit about myself. I'm an endoscopy nurse for more years than I want to own up to. And my current position is the Quality Manager at the Sydney Clinic for Gastrointestinal Diseases at Bondi Junction. I was part of the Task Working Group for the Clinical Care Standard. I'm really hoping at the conclusion of this presentation tonight that you'll all know a little bit more about the standard and that you'll have some really useful tools and resources to help with the implementation. I'm going to call the two Annes and Siobhan the Brains Trust. So they're here to answer all your questions. Now, if you'd like to ask any questions at the conclusion of you can put those into the Q&A tab at the bottom of your screen at any time during the presentation. Mel from the GENCA office is also with us tonight and she will be facilitating the Q&A. Before I start, I would like to acknowledge the traditional owners of the land on which we meet today. I'm on the land of the Gadigal people of the Eora Nation and pay my respects to elders past, present and emerging. 2020, the World Health Organization Year of the Nurse and Midwife. Couldn't have been timed more appropriately, I'm sure you'll agree. Why 2020? Florence Nightingale would have been 200 this year. She actually lived to be 90 years of age in a time when the average life expectancy was about 40, so she did very well. She was a visionary woman and the founder of modern nursing as we know it. Much of her published work concerns spreading medical knowledge in simple English, something we should consider when talking to our own patients and communicating complex medical conditions to them and their families. She also used graphical presentations of statistical data, something that is widely used today, and I will in fact be using some graphs in this talk. On CPD, she said, "Let us never consider ourselves finished nurses. We must be learning all our lives." When they said 2020 would be the Nurse of the Year, they weren't joking. I think everyone can relate to this cartoon. COVID-19 has had a global impact and continues to challenge society as we know it. Interestingly, the principles of pandemic control from the 1800s still apply: sanitisation and isolation. I think in previous centuries, you were doused with carbolic acid and excommunicated and your home was burnt to the ground. So perhaps we've advanced a little. I think we will need our boxing gloves for some time to come, sadly. And a call out to all the nurses out there, and especially the nurses in Victoria at the moment. So the Colonoscopy Clinical Care Standard. Why? Why do we need a clinical care standard for colonoscopy? What is a clinical care standard? When is it going to happen? And how is it going to happen? Why? Well, according to the Australian Atlas of Healthcare Variation, now if you're like me and you didn't know that we had an Atlas of Healthcare Variation, you'll find this very interesting. But according to the Australian Atlas of Healthcare Variation, the number of colonoscopies performed annually, there was almost 600,000 of them in 2013-14, varied enormously from area to area. Some areas were had a 30 times higher rate of the procedure being performed per head of population than other areas. So what did that mean? Did people living in those areas have a greater incidence of colon cancer or bowel disease than other areas? Let's look at the next slide. Now this is a busy slide and I might need Florence's help to interpret it. But this statistical graph shows that the rate of colonoscopy performed directly relates to remoteness and socio-economic status of the population, not necessarily need for the procedure. So if you live in the city in an affluent area, access to colonoscopy is 30 times greater than if you live in regional or remote or lower socio-economic areas. So what is a colonoscopy? What is a clinical care standard? A clinical care standard is a small number of quality statements that describes the care patients should be offered by health professionals and health services for a specific clinical condition, in this case, colonoscopy. It can also be defined as a clinical pathway in line with current best evidence. So in 2015, as a result of the data that they collected, the Commonwealth requested development of a safety and quality model for colonoscopy. In 2018, the Colonoscopy Clinical Care Standard was launched and published by the Australian Commission on Safety and Quality in Healthcare. It was integrated into the National Safety and Quality Health Service Standards, that's our accreditation standards, and it was to be implemented in all public and private hospitals and day procedure centres nationally. The National Safety and Quality Healthcare Standards, second edition, cover high prevalence adverse events, healthcare associated infections, medication safety, comprehensive care, clinical communication, prevention of pressure injuries and falls, and responding to clinical deterioration. The overarching standard of clinical governance basically encompasses all the standards, and if you get it right, the rest will follow. The Commission website lists 7 pillars for effective governance: clinical effectiveness and research, audit, risk management, education and training, patient involvement, information technology and IT, and staff management. The Colonoscopy Clinical Care Standard falls under the clinical governance umbrella. The Commission publishes advisories and fact sheets to assist with the implementation of the accreditation standards, and here's some examples. Clinical care standards. They inform patients about the care they can expect to receive. They guide health professionals to deliver appropriate high quality care, and they identify systems that health systems need to support and monitor appropriate care. The goal is appropriate care for the right person at the right time. The task working group identified 9 quality statements that they felt were relevant to colonoscopy. These are the initial assessment and referral, appropriate and timely colonoscopy, informed decision making, informed being the key word there, the bowel preparation, sedation, clinicians, procedure, the discharge, and reporting and follow-up. And they also developed 4 indicators for local monitoring of compliance. This was the quality of the bowel preparation, the cecal intubation, how often they actually got to the cecum, adenoma detection rate, and more recently, the sessile serrated polyp detection rate. So the first of the quality statements was the initial assessment and referral. So when a patient is referred for consideration for colonoscopy, the referral document should provide sufficient information for the receiving clinician to assess the appropriateness, risk, and urgency of the consultation. And based on this information, the patient is allocated an appointment according to their clinical needs. Because so many of the referrals that you get for colonoscopy, and I'm sure you've all seen them, a box ticked for colonoscopy or for your expert opinion, the Commission develops a resource, a colonoscopy referral template, and it was developed in consultation with clinical experts. This template's been embedded in 5 GP practice software systems to assist with the referral process. And that's a couple of other examples of different GP practice software systems. The second of the quality statements is appropriate and timely colonoscopy. So a patient is offered timely colonoscopy when it's appropriate for screening, surveillance, or the investigation of signs and symptoms of bowel disease, as consistent with national evidence-based guidelines. Decisions are made in the context of the patient's ability to tolerate the bowel preparation and to tolerate the procedure, and their likelihood of benefit from that procedure. If colonoscopy is not appropriate, and it's not always, The receiving clinician advises the patient and their referring clinician of alternate recommended management. Some of the implementation resources that they use for this are the Clinical Practice Guidelines for Prevention, Early Detection and Management of Colorectal Cancer, and the Clinical Practice Guidelines for Surveillance Colonoscopies. And these have been developed by the Cancer Council of Australia. The third of the quality statements was informed decision-making and consent. Now, the task working group felt it was really important that a patient receives this information before starting the bowel preparation. And as we all know, a colonoscopy involves 2 or 3 days preparation prior to actually having the procedure. So before starting the bowel preparation, a patient receives comprehensive consumer appropriate information about bowel preparation, about the actual procedure, and sedation or anaesthesia. Now, in Australia and most first world countries, patients receive some sort of sedation or anaesthetic when they have these procedures. It's important that they have the opportunity to discuss the reason for the colonoscopy, its benefits, the risks, the financial costs, and alternative options before deciding to proceed. Their understanding is assessed and the information provided and their consent to sedation, colonoscopy, and therapeutic intervention is documented. Again, there's some implementation resources, and this one's from the implementation of the Colonoscopy Clinical Care Standard about informed consent. It says, ensure that there is evidence in the patient record of an informed consent discussion between the patient and a suitably qualified clinician prior to bowel preparation. Now, that's not always going to be possible for that to be the person actually performing the colonoscopy. So a suitably qualified clinician can be anyone, including a nurse, who has expertise in colonoscopy and bowel preparation. I'll talk a little bit more about this, the informed consent, when we talk about direct access later in the presentation. Now, the bowel preparation. The single biggest indicator to a successful colonoscopy is the quality of the bowel preparation, and we all know that because we've seen plenty that aren't good enough. So a patient booked for colonoscopy receives a bowel preparation product, a dosing regimen individualised to their needs, comorbidities, regular medicines, and previous response to bowel preparation. The importance of good bowel preparation for a quality colonoscopy is discussed with the patient. They are provided with consumer appropriate instructions. That means in plain English on how to use the bowel preparation product, and their understanding is confirmed. This is a resource from the Commission. It's on their website, so any of the patients that have access to the internet or a computer can play it. I'm going to play it now. It only takes a minute or so, and it's really good.
A colonoscopy is an important test that examines your bowel to diagnose bowel disease and cancer, the second most common cancer in Australia. The Australian Commission on Safety and Quality in Healthcare has developed a clinical care standard for colonoscopy. Find out what you need to know when you've been referred for a colonoscopy. You need to know your rights, your choices, and your responsibilities. You have the right to have your bowel examined by a qualified and well-trained person at the right time and in the right way. Know why your doctor wants to examine your bowel. Receive your results with a clear written explanation so you and your GP can understand what happened in the examination, what was found, and what to do next and when. To be informed about all the things you can do to reduce your risk of future bowel disease. You have the choice to go ahead with a procedure now or later, or choose other options with your doctor. Discuss the medicine you can have to relax you. You have the responsibility to always tell your doctor about your health, your lifestyle, and any cancer in your family. Empty your bowel properly. It may not be very pleasant, but if you don't follow the diet guidelines and drink all of the sachets given to you, you may need to have another colonoscopy. Reduce your risk of bowel disease and cancer. Exercise, eat well, and do the poo test regularly.
So that's a really good little short informative video that you can direct your patients to. So the fifth of the quality statements was on sedation. Now, before a colonoscopy, a patient is assessed by appropriately trained clinician to identify any increased risk, including cardiovascular, respiratory or airway compromise, and the sedation is planned accordingly. The risks and benefits of sedation are discussed with the patient, and the sedation is administered and the patient is monitored through the colonoscopy and recovery period in accordance with Australia and New Zealand College of Anaesthetic guidelines. I think everybody would be following this statement in their workplaces. Clinicians. A patient's colonoscopy is performed by a credentialed clinician working within their scope of clinical practice who meets the requirements of an accepted certification and recertification process. Also, the sedationist or the anaesthetist and the clinical support are provided by credentialed clinicians working within their scope of clinical practice. These implementation resources are really good. They're concise, they're to the point, and to give to the clinicians, the colonoscopists, especially those who haven't certified or recertified. They'd all be certified, but if they haven't recertified, these are informative and give lots of information. They're a helpful resource. So the procedure itself. Now, everyone knows that a colonoscopy isn't a simple procedure. It's a complex procedure and it takes time. So when a patient is undergoing a colonoscopy, their entire colon, including the cecum, is examined carefully and systematically. The adequacy of the bowel preparation, clinical findings, biopsies, polyps removed, therapeutic interventions, and details of any adverse events are documented in the clinical record. All polyps removed are submitted for histological examination, and this helps with collecting your indicators for adenoma detection rate and sessile polyp detection rate. The discharge. Now, this is something really important, and the nurses have a lot of input here. So following their recovery and before discharge, the patient is advised verbally and in writing about the preliminary outcomes of the colonoscopy, the nature of any therapeutic interventions or adverse events, and when to resume regular activities and medications, etc., and any arrangements for medical follow-up. Now, we all know that, the doctor pops out to recovery and says, oh, your procedure went really well. We had a good look around. You had a couple of little pouches in your bowel and a couple of polyps. I'll see you in a couple of weeks. Well, we also know that after sedation, sometimes you don't remember that conversation. So it's really important that there's a written report that goes with the patient as well. And when it's safe to do so, they're discharged into the care of a responsible adult. And that information is also communicated to that person. Reporting and follow-up. Now, this is really important because you don't want people lost to the system. They go and have their colonoscopy and then they don't know what to do. So it's the colonoscopist who communicates the reason for the colonoscopy, its findings, any histology results and recommendations for follow-up in writing to the general practitioner and other relevant clinicians. And people with multiple comorbidities or health problems often have more than one specialist, and the results of the colonoscopy may be of interest to them also. It's also good for the patient to have a copy of their reports, and it's also documented in the facility records. Recommendations for surveillance colonoscopy, if required, are consistent with national evidence-based guidelines, and we referred to those guidelines earlier in the presentation. If more immediate treatment or follow-up is needed, appropriate arrangements are made by the colonoscopist. Now, this would be people who had a cancer found or active inflammatory bowel disease or something like that that needed urgent attention. Again, there's some implementation resources that the Commission's developed. There's a colonoscopy report and a GP follow-up letter. And most of the institutions would have something that they'd be using already, but these are there for reference, or if you wanted to change or look at what they've put on these documents, these reports. There's also embedded in a lot of the scope software is the capability of producing a report. And these are just a couple of examples, Provation and EndoBase. And a lot of you may be already using these. So direct access colonoscopy, I spoke about it briefly before. Now that primarily relates to the removal of that initial specialist consultation. If for some reason that consultation represents a barrier to care that may reduce participation of patients, or it may be because they live remotely and it would be difficult or inconvenient for them to get to a consult and then have to travel a long way back for a procedure, the New South Wales Cancer Council has developed a colonoscopy model of care, which uses a nurse-led telephone triage assessment. It's been shown to be less costly for the patient and allows specialist time to be directed to more complex patients. This model of care has references and supports the Colonoscopy Clinical Care Standard. So when's all this happening? Well, it's happened. The National Safety and Quality Health Standards, second edition, were launched in January 2019, and all facilities should be able to demonstrate their actions toward implementing the Colonoscopy Clinical Care Standard as we speak. How? Well, to take this standard from a document on paper and to see how it worked in a real clinical situation, a pilot study was run between May and August in 2019. It was simulated accreditation against the National Safety and Quality Health Standards to assess feasibility. It was run across 4 sites, and there was a mix of public and private and day surgery. They were in Victoria, Queensland and New South Wales. The pilot findings, there was broad support from the pilot sites and the stakeholders regarding the implementation of the standard, and many of the sites were already addressing most of the colonoscopy clinical care standard. Some of the key areas that still needed to be addressed was the referral system, the appropriate and timeliness of colonoscopies, the triaging, informed consent, the bowel preparation and reporting. So resources were developed at some of the sites and by the Commission to help in those key areas. It was felt that continued stakeholder engagement regarding the clinical care standard is required to ensure that the GPs are aware of the referral template and its importance, and that the clinicians, the proceduralists, are aware of their responsibility regarding recertification and use of the colonoscopy surveillance guidelines, also reporting on the procedure and providing advice to their patients. So more resources needed to be developed by the Commission to help with the implementation and a communication strategy to promote the colonoscopy. And tonight's webinar is part of that communication strategy. So the implementation resources that are available now are the clinician fact sheet, the consumer fact sheet, the colonoscopy poster, the consumer video that we just watched and an assessor video, informed consent fact sheet, the certification and recertification fact sheet, the implementation checklist. There's a wonderful interview with the co-chair of the colonoscopy topic working group, Professor Duggan, who's online tonight. And there's in development are the Aboriginal and Torres Strait Islander resources. All these resources can be found on the Commission's website. And these are just some examples of the fact sheets, the poster and Anne's interview. There's also the templates are available on the Commission's website, the referral template, the colonoscopy report and the GP follow-up letter. Questions?
Thank you, Kathy. I'll just wait till the others pop on their camera.
So we've got the brains trust now. So any tricky questions, I'm throwing over to you.
Thank you. And we have got a few questions. So I'll start from the top. This person's saying they need help to get the old doctors to move along with the certification the young ones have done. Need some tips.
Right. Okay. Well, I'm having a bit of problem with that myself. And I think my facility is actually due for accreditation. So I'm just sort of saying, you know, you have to do it because we've got accreditation coming up. But I think providing the resources as well. And Professor Duggan is a colonoscopist, a gastroenterologist herself. So what would you suggest, Anne?
Yeah, thanks, Kathy. Clearly, some of the older guys perhaps haven't been credentialed or certified and recertified and are concerned that they don't meet the criteria. But it's important to recognise that the aim of this standard is to bring everybody into the camp. It's not to exclude people. And the Gastroenterology Society of Australia did a whole lot of work in promoting standards for endoscopists. So if somebody hasn't done the initial training like a modern gastroenterologist has, there's an EPP, an experienced practitioner pathway, so they can actually be certified that way and be recertified. So it's really important that people are made aware that this is not, the objective of the exercise is not to exclude people, it's to lift the tide, lift the boats with the tide right across the system and make things better. So that's important. And I think people are often fearful that they're not going to make the bar. But the other thing that the Gastro Society does, which many people might not know about, is there have been, until now, and hopefully will restart post-COVID, a whole lot of courses to train people, so that somebody who trained many, many years ago when the technology wasn't the same and it wasn't as easy to see polyps because the magnification wasn't the same and how you got rid of polyps wasn't the same. Well, there's a whole lot of training tools, but there are also online information via the GESA website. Michael Burke and Ian Norton have written a book on colonoscopy, which actually is a very effective way of people realising how to do a good colonoscopy, how to get to the cecum all the time, how to identify polyps, how to remove them. So I would suggest very strongly that people, even if they're not GESA members, think about going to the GESA website, finding out what's going on, and encourage their procedures actually to get their hands on the colonoscopy handbook to see that, and chances are they may very well be good colonoscopists.
I think a lot of them are, Anne, and I've actually, one way I've thought of helping was to actually do some of the logs for them from our facility. So a lot of the time it's a time perhaps thing that people don't want to commit or can't commit the time because they're so busy. And so maybe some admin assistance might help just with the logging procedure as well.
I would agree with that, but I think it is really important, and medicine's moved very much to that view that we really should know what we're doing. We should be actually logging what we're doing. We should be understanding how good we are. We should be seeing whether we actually need to get a bit better with polyp detection or SSA recognition. So it is, I think it's useful to help people, but I think the concept of being too busy to know how good or bad you are is a worry. I'm in the era where we expect partnership with patients. I'm not sure that, I mean, we're all patients. I'm not sure we would accept our procedure as saying, oh, look, sorry, but I've been too busy to know how good or bad I am.
Okay, thank you. We've got quite a few questions, so I'll move to the next one. The local monitoring data seems difficult to obtain. Some surgeons or proceduralists are happy to comment, others are not. Is this data collected at the time of procedure or retrospective after the specimen diagnosis?
So one of the things that the standard, I think, has done has moved a lot of facilities that didn't use electronic reporting systems to using electronic reporting system. And then some of the work that we're doing at the Commission, and Siobhan's leading this, is to try and get Provation and Endobase to develop reports that would allow reports to be run for the facility. So an endoscopy unit can easily collect what their cecal intubation rate is, what their bowel prep satisfactory bowel prep rate is things like adenoma detection and SSA is much more difficult because you can guess what, and some people are very good at with determining what sort of polyp it is, and given the technology with endoscopes, but the final arbiter is the pathologist. So that data has to be collected later, and we recognise that's difficult currently, but we want to work towards that. It's one thing for a proceduralist to know their individual adenoma detection rate, but that doesn't actually give the facility confidence that it's good. So if you thought of a number of procedures working 4 or 5 places, and for example, your scopes were dirty and no one could see anything, just because your procedures overall have high rates doesn't mean in that facility, the facility functions at a high level. So we are working on trying to work out how to make it much, much easier to collect the adenoma data. Part of the problem is that systems don't currently talk to each other. The path systems don't often talk to the endoscopy systems. But this is all part of improving the quality of healthcare, trying to get better IT and getting IT experts to realise that they work for the clinicians, and the system should be working for the benefit of the clinicians and consumers.
Yeah, I'll just add briefly to that as well. As Anne highlighted, we're working closely with some of the software vendors who develop endoscopy systems to improve the capturing of. And I think this addresses some of the questions further down. How are people capturing or facilities capturing adenoma detection and sessile serrated? We do, and we have seen that is a more difficult indicator. They're more difficult indicators to capture. So as part of this project and all the resources we're working on to support the implementation of this standard, we're working closely with the vendors who develop systems to support sites on putting together a specification for them so that they can capture the information in their system correctly, but also we're trying to work out and work together with them on what a user guide for facilities on how to capture the information within the system as well. So although we've 2 main systems that are used in Australia, Endobase and Privation. Privation have been very, both vendors have been working closely with us. So we hope to have something up on our website before the end of this year.
And they're very keen to help us.
They are. I mean, the taking on board as well, Privation have been really, in particular, have been really helpful. And although putting the adenoma sessile serrated information into the system, it has to come from pathology. So they want to work with us to help them get that right in their system.
Great, thank you. So I think that does answer that next question. So the next one is, are there other resources for the elderly other than the information video?
There's the other resources there's a consumer fact sheet. There's also that other video that we highlighted. There's the video with Professor Anne Duggan, which is an interview about the Colonoscopy Clinical Standard. But there's also another video. It's specifically for assessors, but I think it goes into quite a lot of detail about what the colonoscopy standard is and what is needed to be done. So that's also very useful. And other resources we highlighted as well that we're working on at the moment are Aboriginal and Torres Strait Islander resources, which again, the elderly might find useful. And I think there was a question in there about non-English speaking as well. So that's, we're trying to work with a focus group, Aboriginal Torres Strait Islander focus group, to really simplify the message that is in our consumer fact sheet, reduce the length of it, and just simplify the messages in plain English as much as we can.
Yeah, I think they might have meant that for elderly people who didn't have access to the internet, I suppose. So
I think you're
All
right.
right.
Resources can be printed off, and there's a PDF that you can print off from the website. So that could be available in your facility or to send out to your patients as well, or when they're having their initial consultation.
But please tell us about other resources you think that are needed for a large group of people. We're trying to meet the needs of as many as possible, and obviously can't create all resources, but if there's a huge gap, let us know.
Put in the chat.
Yeah, we appreciate the feedback.
Okay, what are the requirements for recertification and how often are the recertification requirements? This includes gastroenterologists, general surgeons and colorectal surgeons.
So for the requirements for recertification are that every 3 years you've done 3 batches of 50 consecutive cases and demonstrated you've met the standard for cecal intubation, for adequate bowel prep, and for adenoma and SSA detection. The actual details of the numbers are on the GESA website, and because I've got a terrible memory, I can't remember. So that is, and for nurse endoscopists, that's the equivalent. So a number of states, or 2 states at least, have nurse endoscopists. Their credentialing goes through their jurisdiction, but their credentials are to the same standard.
Great, thank you. With nurse-led triage, is the nurse a nurse endoscopist?
Not necessarily. I come from Hunter New England Health, and we started direct access endoscopy. I think we're the first place in New South Wales to do it. And we trained up our nurse. She'd never, she was a surgical nurse, but she wasn't a nurse endoscopist. And we in New South Wales don't have nurse endoscopists. But the standard really is that that nurse can explain endoscopy and can recognise when things need to be referred up to a specialist for further discussion. So you want somebody who is experienced and understands endoscopy, understands the risks and benefits, understands bowel cancer, and enough of those diseases to be able to be informed and have an informed discussion with the patient. Because they're in a direct access system, they're discussing, well, they're doing a number of things, risk assessing to see if the patient is a high risk, ensuring the patient just hasn't had a colonoscopy a week ago and therefore it's much better to trace up the old notes, but also having that discussion and making sure the patient has the information, can read the information, and make an informed decision, and then explain the bowel prep to them.
Thank you. Nobody else has anything to add to that one. We'll move on to the next question. Can we not develop a national referral template? This is a constant battle to have appropriate referrals.
Oh, wouldn't that be lovely? I think the magic wand would be worn out with all the things we'd love to have in a sensible system, but it's not to be. It's in the real world of politics, everybody has their favourite tool. But one of the good things about the Commission is that because it's a national body funded by the states and territory and Commonwealth, and it's legislated to lead and coordinate safety improvements, we can do a lot of things, but I'm just not sure that the states and territories or the Commonwealth want us to focus our attention on that yet. But wouldn't that be a wonderful thing?
Okay. A comment and a question. Some clinicians I know do not send a copy of the report with the patient home. How would this be implemented in my facility? All we usually provide is a nursing discharge summary with a what to expect post-colonoscopy info sheet.
Well, you don't meet the national standards, and when you're accredited, you won't be accredited because this standard is part of the National Safety and Quality Health Services standard, which all hospitals and day facilities must meet. So there's nobody and no facility in the country that can function outside the system. And I think that's fair because the Colonoscopy Clinical Care Standard has been put in to try and consistently ensure high quality safe colonoscopy. So I suspect at some stage the penny will drop and somebody will have a quiet word to the proceduralist and say, you've got to tell the patient, you've either got to give the patient a report or in your handwriting, or whatever way you like, but the patient's got to walk out with a document that they can understand that meets that standard, that quality statement.
I think this is probably quite a common thing, Anne, across a lot of facilities, or, you know, not with all their clinicians, but with some. They're used to just having that little chat and say, I'll see you next week, sort of thing. So it is something that that we'll all have to work towards. And like you say, even if it's as simple as you make a template for them to fill out and they write it in their handwriting, that today we found 2 polyps and I want to see you next week, you know, to discuss the follow-up. And this so-and-so is your sedationist or your anaesthetist, and, you know, and this and that happened. And I think there's a lot of situations where that's going to have to be driven by the facility.
Yeah, I think that nurses play an important role in this. I think that healthcare at one stage was fairly paternalistic, and it's very much moved to very much a partnership. That's what the second standard says, partnering with consumers. When I was an intern, which is first year medical student, very long time ago, I had a surgeon who once said to me, when patients ask me questions, I just use bigger words. Fortunately, we've moved a long way from that, but there are still some people who believe that I know best for the patient, but that's no longer accepted by the majority of people. So it is incredibly important to slowly bring people who don't have that worldview along to what is now the only accepted worldview, which is it is a partnership. People choose to have healthcare and are entitled to be informed pre and post their healthcare.
Great, thank you. This one's a bit more of a discussion, but asking how do other units meet informed consent with open access patients?
Right. I think what we used to refer to as open access is something that's going to be bygone. They're going to have to and I think best practice is to see the clinician before your procedure. If that can't happen, then we'll have to follow that model from New South Wales Cancer Council with some sort of, they have to implement some system in their facilities to have a nurse-led discussion with the patients prior to them taking their preparation.
Yes, the only other way that I could see open access being appropriate is if the GP plays the role of that occurs in direct access, where they discuss why they think the patient needs a colonoscopy, what the risks and benefits of colonoscopy are, how to take the prep. And I'm not sure that many GPs necessarily want to do that. In the absence of a GP who's facilitating informed consent, then the patient just turns up on the day without anybody having vetted whether they're appropriate, without anybody having discussed with them the important things like how to take the prep, but also the most important thing about risks and benefits of the procedure. So I think that I agree with Catherine that this is a flag that open access, in pure open access, doesn't stand up to the cold light of day in terms of a process that is about informing people about why they should have this procedure now. Because one of the other things is, in that discussion that you have with the patient about a colonoscopy, is a discussion about when did you have your last, quite frequently, when did you have your last colonoscopy? What did it show? Let's have a look at it. And sometimes you say to patients, and I quite frequently say to patients, well, actually, that was an excellent colonoscopy. It was only done 2 years ago. You don't need another colonoscopy. So a purely open access without that sort of cognitive process, I think, has deficiencies.
I think with all the complicated medications and things that people are taking for diabetes and blood thinning as well, it's fraught with danger as well, because sure enough, they might have been 5 years ago and look, I know all about it, I'm just going to turn up and have it done. But they may have had significant changes to their general health in that time frame. And so they do really need someone to discuss those risks and benefits, and also that the improvement and the changes in the equipment that, you know, we can more confidently say you don't have to come in 3 years because, you know, we have these amazing scopes and, you know, and we're so much better at doing this and the preps are so much better that, you know, we can confidently say that you don't need to have this procedure again. So why would you take the risk if it's not necessary?
I think in the old world, some people didn't trust anybody else's colonoscopy. But one of the things about the Colonoscopy Clinical Care Standard is to lift the bar so that everybody's colonoscopy is high quality. And by giving patients copies of their reports, it means the patient who travels interstate or elsewhere actually can take to their doctor, the next doctor, a colonoscopy report, and there is the information to indicate that, in fact, a colonoscopy is not needed now, it's needed at X point in time. And I think that's the whole point, is we are now trying to move to a situation where every colonoscopy is a reliable colonoscopy, a high quality colonoscopy. And you don't have to, as people did in the past, repeat it just in case the other guy wasn't good.
There's also, you know, there's a great opportunity for nurses sort of to educate patients as well, you know, improve their health literacy about all these surveillance and that these evidence-based guidelines and things that we're using these days, so that the patient can feel confident that yes, they've had a good procedure by a skilled person, so they don't actually have to come every year or every 6 months. There's one that wants to come in our facility every 6 months because she just is terrified of getting cancer. So you know, there's a lot of what's the word I'm looking for?
Yeah.
Communication needed with these people to allay their fears. And I mean, the best person for that certainly is their doctor.
Yeah.
Well,
okay. Sorry.
Nurses are pivotal to this because often patients think the doctor's too busy, but I will talk to the nurse. I think nurses play a pivotal role in that chat.
True, yeah. And often explain it a bit better. I think a bit more time maybe.
Okay, are the recertifications being given an extension?
Because of COVID, there's been a 6-month extension to all recertifications. There was when COVID sort of hit the country, there was a concern at GENCA that people would be flat out doing their day job in an environment of a whole lot of people with COVID. And so there was a decision made early on that there would be just put on hold for 6 months. People can collect their data, and they'll obviously be, if you haven't been recertified, you can collect your data, and then I can't remember when that 6 months is up, but then apply to be recertified. And on the flip side, people who have been recertified before have got an extra 6 months before they have to do recertification again. It's just a product of COVID and trying to plan ahead and not disappoint people. Hopefully it'll tick over again pretty soon. Must be almost 6 months now. I must check that up. Thank you.
Thanks. Why is complication rate not part of the recertification?
That's a really good question. The Commission adopted the GE Society's indicators, which were very much influenced by what was going on in the UK. One of the things about complications are they're very, very rare. You wouldn't, if you're collecting 150 consecutive cases, you wouldn't expect any complications. You know, when we talk about the risks and benefits of colonoscopy, we're talking about 1 in 1,000, 1 in 10,000. So it's just not so common. But because all colonoscopies occur in facilities which are accredited to the national standards, there are other mechanisms to pick up complications. And certainly that should be part of a facility, the things it looks at in terms of safety and quality. So in the governance standard, there's a standard called 1.28, which looks at healthcare variation and expects facilities to provide their data back to clinicians. So that in that context, complications should be picked up by clinical review meetings and monitored and addressed.
Thanks, Anne. Next question. I'm interested to find out how health organisations are obtaining data for indicators for local monitoring.
So am I.
Well, I suppose I could answer that very quickly. When we did the pilot, they were all capturing them in very different ways. Some had built their own little kind of database using Excel spreadsheets, very simply, and others were using an endoscopy system. So there's various different ways that they're capturing. It's very individualized. And some weren't doing it at all, but knew that they had to start addressing that as an issue.
What we're trying to do is certainly create a community of people that, and I think GENCA plays a major role in this, so people don't have to reinvent the wheel. They can learn from other people. It's unfortunate with COVID because the GENCA meeting is usually great for people to get together and talk about what they're doing in their facility. But we certainly want people to be building on the shoulders of giants rather than trying to reinvent the wheel and work out how they're going to do it. There's great expertise out there.
Great. Would you suggest a nurse-led pre-admission clinic to cover a lot of these colonoscopy clinical care standards?
Catherine, do you want to answer that?
I recommend it. Yeah, I think it would be great. Look, there's such a variety of situations where people have colonoscopy. I work in a private centre and most of our patients see their clinician or their colonoscopist prior to their procedures. Other places, the public system, I think there's a real place for nurses to do a nurse-led clinic that to make sure that we're meeting all those quality statements in the standard. I expect, I think nurses can help a lot with the information, communicating with the patients, the discharge process, the bowel preparation, certainly all those quality statements would be, I think nurses would be brilliant at it. It just depends on the structure of your facility and whether they would support that, I suppose.
In the public hospitals, which are under enormous strain, nurse-led clinics for straightforward patients who aren't complex, who need a surveillance colonoscopy, is fantastic. It takes that patient out of outpatients, gives them a very good experience talking to an experienced nurse and understanding, and probably get a better conversation about bowel prep than often happens in rushed outpatients. And it means that you're weeding out people who don't need a colonoscopy, so you're actually not wasting valuable resources doing low-value colonoscopy. So I actually think it's a fantastic way to address some of the strain in the public sector, for example.
And that's only going to be more so after COVID with, with a lot of centres not being able to do routine procedures and things. So there's going to be a big backlog. So certainly I think it has its place.
Yes. Yes.
Okay, we've still got quite a few questions, so we'll move on. GESA has a 3-yearly certification, but the clinical care standard states that the facility has to provide the proceduralist with their annual data regarding the clinical indicators. Is this correct?
Is that correct?
No, I've not come across that.
I don't think that's not. We haven't stated that they need to get it annually, no.
No, somebody might want to put a follow-up question to explain where they've got that from, but it's certainly not the intention, nor I don't think it's anything anywhere written anywhere.
Okay, we'll certainly make a note of the question. It's from Viv. Viv, if you're still there, if you can make a note to follow that up.
Or give us a ring.
Yep.
Later.
Yep. The adenoma detection rate may vary depending on the age group of your catchment population. For example, if a clinic tends to do younger population, for example, less than 60 years old, it may have less ADR than another clinic that does population aged 60 plus to 80 years old. What is your opinion of this?
Well, the actual data collection is only taken into account people over 50. So that doesn't skew your numbers at all. So when you're collecting your data, the ones that are under 50 don't go into the adenoma detection rate, percentage rate. I'm not explaining that very well, but yeah, so we have quite a couple of clinicians who see a lot of inflammatory bowel patients. They tend to be younger. Doesn't mean they don't have polyps, but they're not included in your data when you're doing adenoma detection rate. It's only patients over 50.
I think it also, it's absolutely right, Catherine. I think the other thing it raises is it's really important for people to understand and have someone talk to them about their risk of bowel cancer. As we all know, because we're in the game, in the absence of a strong family history, it increases after the age of 50. But not infrequently, I have worried young people coming along where, in fact, the likelihood of a complication exceeds the likelihood of a cancer or a polyp. So I think, again, this is it's really important in that conversation for people to understand who should be having a colonoscopy. And in the absence of inflammatory bowel disease or something special, it really should be people in the older category who are much more likely to have cancer and can wear the risk because the benefits exceed the risks.
And of course, then there's the hereditary conditions, which are a different sort of population altogether.
Oh yes, the strong family history is a different category. The Lynch Syndromes, they've got their own very strict, regular, and of course that group's incredibly important to pick up and to root and regularly scope, and for them to have a high quality procedure that's not traumatic, so they keep coming back.
And they were actually represented in that task working group that we were in, and weren't they?
Yes, the CEO of Lynch Syndrome was on the clinical care standard. The clinical care standard was developed with clinical experts from all parts of the system, including representatives from the colleges and societies, National Cancer Council, Catherine from GENCA, etc., College of Surgeons, consumers.
Yeah. They gave very good input to that group, though, I found, with coming up with these statements.
Oh yes, it grounded us. There's no doubt it grounded us.
Great. If the patient hasn't got anybody to pick them up, but has somebody waiting for them at home, can you call them an Uber or a cab to go home?
Oh, that's not a sort of part of the standard, but I think as far as day surgery, no, not really. There's organisations that, carers that drive, and other organisations that assist people who don't have anyone to take them home. That used to be a standard practice 10 years ago. We'll hail you a taxi and send you off. That's certainly not acceptable these days. So if people can't get anyone, there's other organisations that can provide an escort who will see them home safely.
Well, it's very useful to know, Catherine, because I had who had a positive FABT test, and 2 years ago had a positive FABT test, and who's absolutely terrified about having a colonoscopy and comes up with all sorts of excuses. And her latest one is that she can't get anyone to take her home. So thank you.
Carers that drive, they're a great organisation. They don't cost much more than a taxi, actually. So
yes. There you go.
So yeah, won't wear that one.
Great. Another one, I'm a DAC nurse, and I'm not up with that acronym, so I'm just going to leave it as that, and was wondering to ask a question about timely colonoscopy. Should it be up to the DAC nurse to decide what category a patient should be booked under for a colonoscopy, e.g. category A within 4 weeks or category B within 90 days, based on the patient's symptoms, or should she consult a specialist if the patient is symptomatic?
Well, a DAC nurse is a direct access colonoscopy nurse. I would have thought that early on you might sort of sit down with a specialist and say, okay, in this jurisdiction where we work, whatever state or territory, what criteria are we going to use for the categories? If you want to see an example of that, go to the New South Wales one that the Cancer Council has just done, and it has, from memory, it has the categorisation of based on the evidence in terms of symptoms. So altered bowel habit's got a low predictive value, iron deficiency anemia's got a high predictive value. So that document is actually really useful for, if you haven't got a system, for working out what your system could be. And then get the sign off of the consultants, and who I'm sure would agree with it. And then you've got a consistent way of dealing with symptoms.
Yeah, it's good advice. I think GESA put out some recommendations as well, because when we went into COVID and we were doing category 1 and category 2, they put out some advice on what was category 1, what was category 2. So those guidelines might help us also.
Yeah. I think the reality is, if you work in the public sector, there is no doubt that the first colonoscopy of somebody who's got symptoms predictive of cancer is going to have many more bangs for your bucks than surveillance. So so there's a lot of science behind it. But you know, starting with the guidelines that are out there is great. And I recognise it's really hard when you've got more patients and you've got slots. And you don't have time to sort of review the literature yourself. But everybody's out there trying to help each other. So it's good to actually pick the brains of somebody else rather than try and do it yourself, because there's loads of people out there who can actually save you hours if you just ask.
Thank you. In regards to the informed consent, can we use a verbal consent? Can we say a verbal consent is acceptable? We have situations in which a clinician, not necessarily the endoscopist doing the procedure, has signed the consent form and written it as verbal consent. Will that be acceptable? Is there anything in writing in terms of what is acceptable?
So we have situations where the endoscopist doing the procedure has signed the consent form and written it as verbal.
It's verbal.
I don't quite understand how that could occur. Certainly, when you have direct access colonoscopy, the nurse is having a conversation with the patient, and the patient's consenting, and after their consent, they're taking the prep. And then when they turn up on the day, they sign the form, and that's really just to some extent acknowledging that the conversations occurred before and is helpful in any sort of legal situation. I just don't understand. I can't imagine why the endoscopist would write verbal, because I imagine the endoscopist has got to have the patient there to be able to have the colon to actually do it. So I don't know why they. So
okay, we might, if that other person can explain that a little further.
Yeah, that'd be great.
The quality of bowel prep is very poor, especially in the elderly. How important is following a white diet as well as bowel prep instructions? Is there any evidence that inpatient bowel prep is superior?
Well, I have never found that inpatient bowel prep is superior, I have to say. Elderly people are often on a lot of medications, so, and some of those are constipating medications. So I think it's really important to actually to have, and this is one of the reasons why I think it's important to have the consult with elderly people, to find out what they're on, to find out how constipated they normally are, to find out whether they normally take Metamucil or what they normally take. And sometimes they need more prep than other people. I do think if with a good conversation, a good discussion, you can get better compliance. In terms of the white diet, I play around with the white diet in terms of how much I ask people to have the white diet, because some people just find that they just get really constipated with a week of a white diet. But I certainly make sure they have it on the 2 days before, you know, the day before being fluids. But it's worth looking at the literature on that.
I find elderly people are very compliant with, much more compliant with bowel preparation if you have a good discussion with them. I think they read the information, they actually take the time. It's sort of these busy sort of executive types that ring up and say, oh, I only read this today and I'm having my colonoscopy tomorrow. You know, like, what should I do, sort of thing. So but I think it is important to, yes, like Anne says, with all the medications and things. So having a good history about what their normal bowel habit is can help a lot with sort of making a prep that suits them. So individualising it, I might say. We often go to some of the old preps for the the oldies, you know, back to the GlycoPrep 3 litres or the combination GlycoPrep, PicoPrep, and add in some something for 2 or 3 nights before to help things along. So I think it's getting the history and having the discussion, and most of them are very compliant.
And I think it's important to explain to people what they're trying to do. You know, I talk about the stomach churns things up, the small bowel absorbs food, and the large bowel is about residue. It's about the non-absorbable fibre. And I think it's really, if people get what they're trying to achieve with bowel prep, I think they're much more likely to be compliant with white diets, with lots of fluids, with all the bowel prep. It's not rocket science that if you know what you're trying to do and why you're trying to do it, that you're more likely to do it. And of course, in that conversation is the discussion about if it's great prep, then every polyp that is, you know, not every polyp, obviously there's a miss rate, but we're much more likely to see polyps and much more likely not to need to repeat the colonoscopy. And I think people appreciate understanding, geez, that makes sense. This is not just somebody imposing terrible fluids on me.
Yeah.
Right. A couple on wait lists. Anne's just ducked out, but we'll go on. How are other units managing an overwhelming wait list? The need for a timely colonoscopy seems to be lost with the size of the wait lists that we have at my facility, not to mention the pressure this puts on the clinicians. And the next one is a similar one.
Oh, I missed that.
Thought you might. So how are units managing overwhelming wait lists? The need for a timely colonoscopy seems to be lost with the size of the wait lists that we have at the facility, not to mention the pressure this puts on the clinicians.
Well, I think that the colonoscopy clinical care standard is designed to help those wait lists. And I think we should also be looking at gastroscopy, which obviously takes up a lot of the time in terms of the opportunity costs. So if we get really, really good at prioritising, then I think we'll be a long way ahead. I think patients don't mind waiting if they know that the person ahead of them is in more need, the person behind them is in less need. Now, I've lost the rest of that question, so I can't answer any more about it.
Oh, because I dismissed it and said you'd already answered it, sorry.
Okay.
So it's about putting pressure on the clinicians.
Yeah. I think there's good evidence there's still room for improvement. I think we can get a lot better with the current resources we have.
Okay, is there a push in Australia to use the national fact sheets, particularly in relation to the patient information instead of information written by the individual facilities? Here in New Zealand, hello to our visitors across there, it seems each district health board area has developed their own, which seems like reinventing the wheel.
The stance of the Commission has always been not to mandate, but to support the system. So if people want to do their own, they can, but we try to provide resources to save people time developing their own. Now, having said mandate, every so often the health ministers say things will be mandated, like the national standards for accreditation of hospitals. They decided that you had to be accredited to function in Australia. But the Commission itself tries to be supportive of the system and help, not beat it, so to speak, with a stick. And hello to New Zealand. Great to have you on. Well done with your COVID response. Well done.
I think they're back in lockdown now.
Oh, I haven't heard today's news.
Yeah, it's just news this evening. Won't go there. Just a comment. We have open access at Western Health and we consent on the day of procedure.
Yeah, is that consent? What happens if the patient's turned up, having had their prep, and then in a discussion you discovered they had a colonoscopy 6 months ago? I think that we really need to think through the whole issue of what is informed consent. Because informed consent is about the risks and benefits. And if you've just had a colonoscopy, the benefits are very small of having another colonoscopy, but the risks remain the same. So something to think about.
Thank you. In private hospitals, informed consent is at the consulting rooms and difficult to obtain evidence, only the consent form. The anaesthetist sees the patient just prior to the procedure.
Well, I think that the consent occurring in that's fine. We have to trust each other to some extent. I'm not concerned that the consent process occurs in the consulting rooms. I'm talking about anaesthetists that's sort of out of my area of expertise, so I couldn't comment on that. I would imagine that some anaesthetists might not. Well, I would hope that most anaesthetists, even if they saw them before the procedure, if they thought it was high risk, they'd cancel the patient.
Yeah, that's pretty standard practice in private practice. I think that the anaesthetist sees the patient just before, or if the clinician thinks that that they need to have a consult with the anaesthetist prior to their procedure, that can be arranged. So I think sort of freestanding day surgery, sort of the patient cohort is has less risk. They're not without risk, but they have less risk. So it's pretty standard practice, I think, for the consult to occur with the anaesthetist or the sedationist on the day. And yes, yeah, so we have had instances where they've said, no, I'm not happy to go ahead with this. And so then you have to reschedule in a safer environment.
Yeah. A lot of people, because we have a bowel cancer screening program in Australia, a lot of people are otherwise fit and well and are very low risk. So it makes sort of sense.
That's right, yeah. So that's the type of patient, yeah. So that maybe the direct access and the consult with the anaesthetist on the day is okay in that cohort of patients, but there's others that perhaps it's not so okay.
And most consultants will send high-risk patients to facilities where...
of course, yeah. Like, yeah, you've got to trust their judgment as well.
Mm.
Okay, would it be appropriate for a nurse to discuss the colonoscopy preliminary findings upon discharge if the patient asks?
Well, we're supposed to be giving them that information anyway. So, yes, I often talk to the patients. It's usually after the clinician said, oh, you've got some pouches in your bowel or something, and they might ask, and I would often talk to them about what that is and what it entails. And so I don't know, what do other people think? I often talk to the patient about the findings, but I don't give them the results of the test. They've already received that from their doctor.
Look, I agree, as long as everybody's on the same page. There's nothing more irritating for a patient than to get two different messages. So if everybody understands and working together as a team, that's and often, you know, the doctor might say something and walk away, and the patient sort of mulls it over and really wants to understand it better. So the nurse is in an ideal position to help out and explain things there.
Sometimes they can't read the writing on the report. If it is a handwritten report, you know, they're saying, well, you know, what does that say?
There's no excuse now, Catherine. They've got a template.
Well, you know, we're going to cover all bases.
Okay, the revised MBS numbers certainly created a lot of conversation and private billing issues. Do you think this has tightened the occurrence of unnecessary procedures?
It was certainly designed to improve the appropriateness of colonoscopy. It's too early to tell. It's only the first review's just occurring now. I hope it's raised awareness among clinicians who hadn't sort of thought it through before, that there's really good evidence base for when people should be having surveillance colonoscopies in particular. I think it's so unfair on patients to be subjected to colonoscopies unnecessarily. So I was on the, I must declare that I was on the MBS committee and chaired the committee for gastroenterology, and our objective was not to deny anybody who needed a colonoscopy, but it was to try and put guideposts around particularly surveillance colonoscopy, so it was easier for people to remember what appropriate timing was for surveillance colonoscopy. I hope we've actually achieved our goal. But certainly the MBS and we are very keen to refine it if it needs more refinement.
Great. Does the standard appreciate that the quality of the colonoscopy is also related to the quality, age and model of the colonoscope used? For example, an old 160 versus a new 190 dual focus colonoscope.
Yes.
Leave that for you, Catherine.
Well, I suppose you can't have separate standards for different equipment, but yes, there is a difference in the quality of the colonoscopy. You perhaps have to, it takes a lot longer with older equipment. You have to be even more careful, I would imagine. Yes.
And I think that one of the things about the standard is it's trying to sort of get the message out there is, you know, what we should expect as consumers in Australia. So we should expect a endoscopy system report. We shouldn't expect a scrawly handwriting which says normal. And we expect our colonoscopy to be done using the latest equipment. So it is trying to actually, as I say, lift the tide.
Great. There are a few comments just in relation to that previous question about the verbal consent. A couple of people just saying that it was thinking that the consent discussion had been held over the phone and the patient not being there to physically sign the form.
So I think verbal consent over the phone's fine. I mean, we live in Australia, it's the tyranny of distance. It's the quality of the consent, and the written signing of it is just a sort of, is really a documentation that's occurred. And a handy way of remembering that it has occurred and an opportunity for the patient to change their mind. But I think, you know, particularly post-COVID, I think a lot of healthcare will be over the phone. On the day the patient can just confirm it or change their mind and sign the form.
Okay, great. Yeah, there's a bit more about verbal consents, people in taxis. Is it the day hospital's responsibility to provide patient information on their procedure, or is the room's responsibility to provide this information?
Well, I think there are different setups and maybe Catherine, you could comment because I know far less about day hospitals. Certainly where I work, at the end of the procedure, I provide information and then I dictate a letter. So provide a copy of the report and then I dictate a letter to the GP and a copy to the patient which explains what I did, what I found, what I think should occur next.
I think in day surgeries, with a lot of VMOs coming, it varies from doctor to doctor how they manage that. But some of them, like say, they dictating their own reports and printing them out on the day or writing them by hand on the day. Some use the medical typists that we have. Some of them use, so it's very much an individual thing, but it's really up to the colonoscopist to provide that report and that information. And they have to liaise with the facility at how they can do that.
I think the point of the clinical care standards was that we got experts around the room to look at what quality looked like, what best practice looked like, and we tried to move the system towards best practice. So I think in some situations, the sensible thing is to think about, well, what's best for the patient? How can we do this that actually ensures that the patient gets the best outcome? So rather than sort of arguing about whose job it is to do X or Y. I think if you go beyond the standard and do the best.
Yeah, you can work together on that, you know, you can work with each of your doctors or how they want that to look on the day. I agree. I think it's a team thing. It's the doctor and the nurses and the facility all sort of making sure that the patient goes home with that information in whatever format that they can manage.
Yep.
Okay. Does a public hospital do staggered admission times?
Oh, I think that's out of our area of expertise.
No idea.
Yeah.
Some maybe do, some maybe not.
Yeah. A few more comments about.
In Fiji, they all just turn up at the one time, so and wait all day and never complain. But I wouldn't think that would be the case here.
A comment on the new the new NHMRC colonoscopy surveillance guidelines have been quite extensive. The summary of that document is 45 pages long. Is there perhaps a summary of the summary?
We'd love there to be a summary. We've tried to encourage that. It's always, I think, important to translate evidence into a usable, workable format that people can refer to and use. Excellence is sometimes the enemy of the good. So I think there's some European guidelines which are pretty straightforward and consistent with the evidence and a high-level evidence. Sometimes we go down to low-level evidence, we get very complicated. I'm hoping, because we'd like to be able to put out something that's sort of a one-pager that simplifies it all. I've been in conversations with some of the other authors on the guidelines. I do the primary prevention chapter, so I can't be held responsible for the surveillance guidelines.
I think that's what I like about most of the fact sheets and things available from the Commission is, about the standard is that they're usually one page, they're easy to read, they're to the point, you know, everyone's got time to read them. So a lot of those resources I referred to in the presentation available on the Commission's website are exactly that, concise and easy to read. But like I say, with the guidelines and things, well, that's sort of out of my league as well. So,
thank you. We've just got one more question. There are a few comments in the chat which we might address later on back to those people who've asked them. But just a question, is there a need for a gastroscopy clinical care standard?
Good question.
I thought it was good. That's why I thought I'd ask it.
It's a great question. It's a great question. I'd love to do a gastroscopy clinical care standard. I think that there's so much opportunity there. I think all the time I see people who are worried about their risk of esophageal or gastric cancer, and then I pull out the data from the Australian Institute of Health and Welfare where there's a little calculator. You can calculate the population risk given your gender, given your age. And I remember seeing somebody who was quite elderly, never smoked, never drank, and she was sent along by her GP. And I said, well, your risk is something like, I don't know, less than 10 per 100,000. And she said, well, that's ridiculous. I'm going to speak to my GP about that. I think there's great opportunity to improve general awareness about risk and articulate better the role of gastroscopy. And if we did that, I think we'd have more resources available for colonoscopy, which, and of course, bowel cancer is 10 times more common than upper GI cancers. So I think we could do an inordinate amount of good for the Australian population. But they have to be on the list of all the other things we've got to do clinical care standards on. But thanks for the question.
Great. All right. I think there's a few more questions and things, but I think that we've probably gone about half an hour over time. So, Anne, over to you.
Well, I would, on the behalf of the Commission, like to thank Catherine and thank GENCA very much for hosting this session tonight. And I'd like to thank all the participants from, I can see people from all parts of Australia and New Zealand. Thank you very much for your enthusiasm for hooking up tonight, but also for providing questions. And I'd like to invite you to keep sending in questions because if we can help you to improve the quality of the system you provide, then we'd love to do that. If there are resources that we haven't provided that you think really there is a burning need for them, let us know. But otherwise, have a great night and thank you.
Thank you.
Mel, were you going to ask us, do a poll with those who've left? Who we've left online?
Yes, I am.
Fabulous.
Oh, wow. Okay.
And if there are further questions, they can send them into GENCA and I'll hand them on to the Commission. I've just put the email address in the chat box.
Fantastic.
Wonderful. And we'll endeavour to get back to you. Thank you so much, everyone.